Thank you, Brent. I appreciate being the last of the best. This has been a really great meeting. Unfortunately, I had a situation where my plane was canceled twice in a row. I couldn't believe it. So I only made half the meeting, but the half that I did see was just an excellent meeting. I really applaud the meeting coordinators for this meeting. Well, I have the task of being the chair of the TG 259, and we have been assigned a really difficult task to decide whether non-physicist individuals should be doing physicist tasks. And the question is, should the AAPM be involved? I think a lot of you have understood that there's been a lot of discussion, some of it heated, some of it controversial, regarding should we start a new type of physics position. And from my perspective as the chair of TG 259, I'll just tell you that I'm a diagnostic physicist and I've worked in diagnostic radiology for 33 years at UC Davis. It's been my one and only job. I felt really fortunate about that. But in an academic situation, it's a little bit different than it is in a consulting situation. And we've heard that time and time again. It's different for diagnostic physics than it is for therapy physics. And we're really sensitive to that as well. To give you an idea of how did we get where we are, I'm just going to do a little bit of a historical perspective. Oh, but first, learning objectives. What I and Per, who's going to be doing the therapy side of this presentation, are going to help you understand the reasoning and the need for this medical physics practice guideline, to understand the MPA QMP supervision responsibilities, and the most contentious issue is what should the ratio be. And we'll talk about that. And Per is going to give a lot more insight into the radiation therapy reasoning for a smaller ratio rather than what we recommend for diagnostic and nuclear, and understand the competency levels of the MPA. When this particular task group was assigned these duties, it was separated from the professional council. This is a professional council effort, and then there's an educational component too that I'm going to just briefly refer to, and that's task group 276, to discuss and recommend the education requirements for the MPA. And there's a lot of people out here, oh, and by the way, just by a show of hands, who doesn't know what an MPA is in terms of what their tasks are contemplated to be or expressed to be? Don't know what the MPA is. Okay, so I see, keep your hands up just for a second. Do you see that, Lynn? How many know what an MPA is? It should be the inverse of what I just saw. Okay, that's good. How many agree with implementing a practice guideline discussing the aspects of MPAs? How many disagree with that? Okay, so we have about a handful that disagree, and the majority agree that we should at least take a stance. Okay, and it is controversial. There's a lot of discussion and chatter on the Medphys, the Phys server that I don't read, but the BBS there was as well, the AAPM BBS. So where did this all start? Historical perspective. In 2011, I was president, and I'm glad I'm not president now. But it was a really fun time. We were sitting in the Pan American Hotel, and we had this little ad hoc committee, a presidential ad hoc committee, and we said, you know, we really need to do something about what procedures and tasks the diagnostic QMP needs to personally perform in terms of clinical practice, and determine what types of individuals that QMPs should supervise, and these types of supervision for different circumstances and tasks for the trainees of medical physics, the medical physics trainees, as well as for those such as quality control and quality assurance individuals. So what we wanted to do is determine the allowable procedures and tasks performed by an unqualified assistant. And the unqualified assistant was the trainees and what we have deemed historically a quality assurance technologist that would help in that task. And notice that it was only for diagnostic because there is a little bit of a difference in the way in which diagnostic physics is presented out in the real world. So a lot of consultants and a lot of individuals that do use these non-physics individuals or unqualified assistants. So we started that in 2011. So we have the draft of 5/31/2011 where we began this ad hoc committee, which as a result of the membership, and we had discussions with several other individuals that weren't specifically mentioned as the membership, but we did have a charge, and we then decided that why are we just limiting this to diagnostic physics? Why don't we go ahead and expand it to therapeutic and nuclear medical physics as well? So in January 14th, 2013, we initiated the Task Group 243 and its corresponding medical physics practice guideline number 3. Focus levels of supervision in clinical medical physics. And what this charge was is, and I'll just go ahead and read it, produce a medical physics practice guideline defining the role of the QMP for supervisory oversight of the medical physics student, the medical physics resident, and the quality assurance assistant for designated medical physics tasks and concurrent responsibilities of each party. Now, the thing that really raised a lot of ruckus, and I think this was the most discussed item in the annual meeting of 2013, was the fact that we were going to provide a medical physics practice guideline for non-medical physicists. You say, wait a minute, what's the deal with this quality assurance assistant? Why are we dealing with that? And that feedback that we listened to as a task group, and the fact that one of the biggest issues was the recognition of non-medical physicists, that we retrenched. So we redesigned the task group. We eliminated the components that related to the non-medical physics tasks, for instance, for quality assurance assistants. As you can see in this one draft, here it is blocked out, and we forged ahead as a task group 243, and we retrenched to target only those individual medical physicists that are students of medical physics, that are in training, or as medical physics residents. They have individual definitions that are listed in the now current medical physics practice guideline. The medical physicist in training is an individual who has met the requirements and is currently in the process of completing board certification to become a QMP. The medical physics student would be one that's enrolled in a master's or doctoral degree granting program from an approved institution, CAMPEP accredited, that is on his or her way to becoming a QMP. And then, of course, the medical physics resident who has gone to the next level and enrolled in a structured training program designed to educate and train at a level of competency to become a QMP, meaning that you can practice medical physics independently. So that was our target group. So it made it a little bit easier for us to go ahead and complete this particular medical physics practice guideline. And we went through the machinations, and of course there was a lot of discussion and discourse about, well, how many students are allowed to be supervised by a single QMP, and what are the mitigating circumstances? And you can read all about it. It's been published as a peer-reviewed article in the JACMP. It's volume 16, number 3 in 2015. And it explains the levels of supervision for medical physicists in clinical training. So with that, we have some recommendations that I'll just refresh your memory about. It gives us a little bit of a background for where we're headed for the MPA. So this provides a framework for the appropriate supervision and scope of responsibilities for medical physicist students and residents and medical physicists in training. And the bottom line, if you go down to the bottom of the slide, except under documented extenuating circumstances, for instance, somebody gets sick, there's a job transition, a supervisor must not supervise more than 2 medical physics trainees at one time, more than 2 medical physics students. So this was the recommendations of the committee and what is now the recommendations of the medical physics practice guideline. So in the meantime, what's happening? Well, things just don't stop because we just limited our practice guideline scope to trainees and those in the pipeline as medical physicists. The fact is that when we look back at 2014, and as a member of the American Board of Radiology, which is now in the process of only allowing individuals, current individuals in the pipeline to sit for the American Board of Radiology exam. In 2014, of course, now everybody has to go through a medical physics residency. There are some other programs for external international individuals, but they're pretty specific and pretty rigid as well. But what has that led to? That's led to a lack of residency slots for the number of medical physics training graduates seeking a medical physics career in clinical situations. It's now led to many trained individuals that can't get into a residency, that are very well trained in medical physics seeking opportunities. So now we're starting to see this growing number of medical physics educated and trained individuals that can't get through the pipeline. And with existing current infrastructure, the assistance for medical physics services has been around for a long, long time. I've had a QC tech at UC Davis since I've been there, for the most part. The fact is that now it's evolving into this coalesced group of individuals that might have an impact on what we do as medical physicists. So we're going to have to talk about this, and Per and I want to have a discussion about some of these issues. And Lynn, who is the AAPM staff member who has been taking and tracking all of what we've done, is going to help us out in listening to what the feedback is here at this particular setting as well. So the fact that there's continuing efforts to reduce the cost of health care, and when you read on the bulletin board and others that there are medical physicists that think, well, this is just the way in which things are going to evolve. We live in changing times, we have to change with the times. The fact that you can provide individuals that are very astute at doing a specific job. Oh, by the way, just as an aside, my QC tech can go into a room and do a hell of a lot better job than I can as a board certified qualified medical physicist, just because he has been doing it for a long time and knows the specific attributes of what can and should be done. But outside, what happens when something happens outside the box? That's where we come in. And if you read that point-counterpoint that was in medical physics by Dr. Fontanella and Dr. Azell, they actually talk about some of those issues of what happens when you do have a MPA, and what's the rationale for being for or against that notion. And I really recommend, I have another slide on that, but I really recommend you read that article. So looming accreditation and regulatory requirements, we have now the Joint Commission requirements in diagnostic radiology. Everybody needs to be accredited for this and that and the other. And there's just going to be a need for being able to distribute some of that workload from the QMP, who should be doing more patient-related as opposed to technical-related skills. At least that's some of the arguments that have been made. The bottom line is there's no guidelines for supervision of these personnel that are now starting to come onto the scene in greater and greater numbers. So what are we going to do? Do we stick our head in the sand and say, oh, we're not going to have anything to do with it? In my opinion, we shouldn't be doing that. So what about the QA Tech / MPA? Well, first of all, we had to say, well, who is an MPA? And I'm going to define that, and I think Per is going to talk a little bit about it as well. But these are individuals who have completed a medical physics training program but are unable to complete the process. They're technologists or therapists interested in medical physics tasks, maybe moving away from and seeing a different venue for their benefit of their position and job opportunities and the like. Individuals from other related fields, health physics, clinical engineering, vendor service personnel that want to get into these arenas. And then the off-street entrepreneurs. there's always a back door, and that's the problem. Those are the types of people that we want to prohibit from being able to practice as an MPA. Well, at least that's my opinion, and I think that collectively as a medical physics group, those are the individuals that we really need to concentrate on. So, what has happened now is the medical physics practice guidelines number 7. This is task group 259 on medical physics extenders, and here's the charge. I believe that Per is going to talk a little bit about it as well, but determine what procedures and tasks can be delegated by a QMP to a medical physicist assistant in the clinical setting. Determine the allowable procedures and tasks performed by an unqualified assistant under the supervision of a QMP and the level of supervision for different circumstances and tasks. This was started on March 14th, 2014. And one of the things the first things that we did was just coalesce all of these different types of names, like a quality assurance assistant and other names that are given to these individuals as a medical physicist assistant, not a medical physics assistant, a medical physicist assistant, and there's a lot of reasons for it, for saying that. So that's the medical physicist assistant. These are the members of the task group 259 and the medical physics practice guideline as of March 2016. We've had a couple of defections because there was a couple of members that disagreed with what we were doing, and they resigned, and hated to see them go, but they did. And there was some ACR involvement, but there was some issues related to how we defined a QMP and other things that they didn't agree to, so they were no longer participants in this effort. All of these individuals, we have a really nice mix of diagnostic therapy and, to the extent that we can, nuclear medicine. It's just there's so few numbers of nuclear medicine physicists. But I believe that this particular group of individuals provides a nice cross-section of individuals that have different viewpoints regarding this situation. And we all, I guarantee you, we did not agree on a lot of issues, and we probably still don't, but we have come to a consensus, and I'm going to talk about that as we move forward. We had a face-to-face meeting that was really valuable in January of 2015, where we produced the basic structure of the document. We learned a lot from doing TG 243 and developing that medical physics practice guideline. So this is an extension where we didn't want to put our head in the sand and say, oh, we just don't want to even discuss the MPA because we don't think that that's a good thing. On the contrary, we definitely wanted to provide at least a stance on how supervision needs to be implemented. So the most discussed and contentious issue, as you can understand, and what brought up a lot of discussion at the annual meeting in 2013, and actually in 2014, and 2015 too. I mean, this has been an ongoing issue. The initial draft indicated that we would have no more than 4 FTE MPAs per QMP for diagnostic and nuclear medicine. Now, why 4? Well, we had several members on the group that says, well, I work at institution X, and we have quality assurance technologists, we'll call them medical physicist assistants, that go to this place and that place, and we have a huge number of outpatient facilities that just have a single radiographic room and a simple fluoro room, those kind of things. And we don't have the time, we being the medical physicist QMP, don't have the time to go out there to do those types of measurements. And because of that, we don't want to be limited in how many FTE MPAs we can have. Well, we heard a lot about that, and then in the radiation therapy group, the physicists on the committee said, well, you know, we're talking about MPAs that are going to be doing specific individual small tasks, and we don't want any more than 1/4 FTE, 0.25 FTE MPA per QMP. So what does that mean? If you were going to hire an MPA full-time, you'd have to have at least 4 QMPs on site within the radiation therapy department, something to that ratio. And that, they've stuck to their guns. What we did was we heard a lot of the feedback, and here's some of the feedback. Just by recognizing the MPA, we are legitimizing their existence. Well, if we don't at least recognize them, there's no way we can provide any recommendations on how many MPAs should be supervised by a QMP. A difference of 16 to 1 between diagnostic and therapy practice is too much. Well, in retrospect, we agree with that opinion. It's too much. 16 to 1, are you kidding me? That's what everybody was saying. So we've backed off on that, and you'll see what we've done. I am really concerned about the 4-to-1 ratio for diagnostic supervision. And these are individuals that are working out as consultants in the field as diagnostic physicists. We heard them, and we heard them several times. Consulting groups with 10 QMPs can hire 40 assistants and take over all private consulting physics services cheaply. That's another big concern, particularly for those private practice consultants, which there's a lot of in diagnostic radiological physics practices. And this is a concern. And it's probably one of those issues that has been a hot button of contention based upon that particular ratio that we espoused. Take a lesson from the medical dosimetrist. Now, a lot of you realize that the medical dosimetrist evolved out of the fact that things got so busy. And are you going to talk a little bit more about that, Per? Okay, I'll just leave it at that. But now there are more dosimetrists than physicists in a lot of areas. So, you know, those are the beware of history, you know, kind of like thing. We are creating less QMPs and opening the market for MPAs. Well, I don't know even how to respond to that. I think we have enough residencies to meet the workforce needs. I believe now we're pretty close to status quo. What we're going to have to do is make sure that we feed back further upstream when the medical physicists are being produced as graduate students, that they understand that it's just not all clinical types of procedures and job opportunities that they can go into, number one. And number two, maybe we need to back off the number of graduates that we're producing. But who's going to do that? Right? You see these schools that are cranking out MS medical physicists, and it's without having any specific thought about where they're going to go and what they're going to do. MS medical physicists are being replaced by MPAs. Well, there's potentially a lot of medical physics tasks that might be replaced by MPAs, and that's something that we can talk about. Reality check. Physicist assistants under many names have been around for a long time, as I'd already discussed. States are now enacting statutes recognizing the existence of MPAs. It's the states and the statutes. Did you put that in there, Lynn? Statutes, which of course are the way in which individuals can then implement regulations to require MPA, or at least recognize their existence and put down requirements for what their entry-level capabilities are. It is time for the AAPM to step up and create practice guidelines for regulators to consider when enacting state policies and regulations. I mean, I think that's true, and I think that's kind of my opinion. It would be a mistake to ignore the situation. We cannot afford to ignore the situation, despite the fact that there are some that think that we should totally ignore it altogether. That again, is my opinion. So what's happening? Well, what is happening in the states? In New Jersey, they have existing policies for the MPA, and they actually call it a medical physicist assistant in diagnostic medical physics, but it's extremely limited and pretty rigid. It's limited to radiography and fluoroscopy. So we've taken a little bit of some recommendations based upon these regulations in New Jersey and defining our practice guideline to be limited in scope in diagnostic, and I'm sure that Per is going to talk about what the limit in scope is for radiation therapy MPAs as well. These individuals must be certified by the state, which requires a minimum qualifications for certifications, and those certifications are entitled Qualified MPA in Radiography or in Fluoroscopy. And here are their educational requirements. Unfortunately, they have escape hatch as well. One of the requirements is an ARRT certification with 5 years experience and 1 year experience performing QC tests. Or if you have the quality management certification with the AART, it's 3 years experience and 1 year experience performing QC tests. A bachelor's degree from an accredited institution in related field and 4 years of experience performing QC tests. A master's or doctorate degree from an accredited institution in the related field and 2 years of experience. So you can see you have sliding amounts of education versus experience. But here's the kicker that's kind of opens the door to almost anybody. No explicit qualifications, but pertinent experience. Now, as long as the pertinent experience is kept at the same level as those others, then that might be okay. I had a discussion with XCOM yesterday, and they're saying, hey, you know, what we need to do is make sure that the educational requirements are somewhat firm in terms of requiring a bachelor's. So we would up the ante in terms of a recommendation beyond what the New Jersey regulations are, that a minimum requirement would be a bachelor's in a physics or closely related area. In addition to, you could have a BS RT, for instance, have ARRT certifications. We'll get back into that again. So then they go on to we look at the regulations here, and these are this is the application for certification. So you have the applications, the qualified medical physicist assistant in radiography, the qualified medical physicist assistant in fluoroscopy, and what can they and can they not do. All the other advanced imaging equipment requires a QMP in New Jersey, by the way. So the assistant is prohibited from performing any QC survey, and this is for fluoroscopy, on digital fluoroscopic units or fluoroscopic units located in dedicated interventional special procedure suites. So they do have limitations on what these individuals can do. If we take a look at a medical physicist radiographic QC survey, they actually go further and say, these are the things, you can't see it very well, but this is highlighted where my mouse is pointing now. These first 9 items are what an MPA under general supervision can do as long as that particular individual has been qualified and it has the certification. They cannot perform image quality evaluation. They cannot review the facility technologist QC test records. They cannot report. Well, if they can't, who does it? It's the QMP that does that. Interestingly enough, and these are the allowed tasks by the MPA under general supervision by a QMP. Interestingly enough, for fluoroscopy, they have these first 7 categories, and then the 9 and 10, they can't do half value layer alone, which I kind of found interesting, and I'm not quite sure what the reasoning for that is, but they can do all of these nominal types of tasks, including a KV check and fluoroscopic spot film collimation assessment. Now this is on the non-digital systems, by the way, but what they can't do is listed as 8, 11, and 12. So these are specific regulations by New Jersey. Just to give you a flavor for where we perhaps, and what we're doing in MPPG 7 in terms of delineating responsibilities for the diagnostic physicist, delineating responsibilities that the MPA can do for nuclear medicine tasks as well, and as well for radiation therapy tasks. In Texas, this was given to us by a former Texas member of the, are you still licensed, Jessica, in Texas? But you gave us this information as a member of the task group. So we looked at what was going on there too. So what this is they recognize the fact that there are assistants being used by licensed medical physicists in Texas, and these set basic parameters on the use of assistants by medical physicists licensed in the specialties of diagnostic radiological physics, medical nuclear physics, and medical health physics. They're silent on radiation therapy. And so if we drill in a little bit, and I'll just expand these out so we can read them a little bit better. The board recognizes that there are many successful assistant/licensed medical physicist relationships, and that such collaboration is necessary given that there are thousands of single-tube X-ray units located in physician, dental, podiatry, chiropractic, and veterinary offices and urgent care clinics. But they also go on to say these individuals must be properly trained and approved by the medical physicist, in the licensed medical physicist, I think they infer here, in the techniques of performing the tests, the function and limitations of the imaging equipment and test instruments, the reasons for the tests, and the importance of the test results. And given those requirements, these tests could be performed under general supervision of the licensed medical physicist, who is responsible for and must review, interpret, and approve all data. Now, when you look at what we wrote in MPPG 7, we've kind of usurped and lifted a lot of these types of things that we've talked about in our document. Now, there's been lots of meaningful discussion. Lynn really nicely gave us a list of some of the summaries of what was going on the Medphys listserver as well as the bulletin board. And here's one article that I think everybody should read. Medical physicist assistants are a bad idea. And it's by Drs. Fontanella and Ezel. Really nice discussion about that. And Dorsey is against, or she's for this proposition that medical MPAs are a bad idea because they're going to displace QMPs. Now, that may or may not be the case, but when you think about how you identify these individuals that can help us do our job, and we restrict them to do those things and not go beyond those values, is what we're trying to accomplish in this medical physics practice guideline. So on the Medphys listserver / AAPM BBS, these are some of the summary things, summary of issues and concerns that were discussed. And these are available as summary documents. Summary of issues and concerns include QMP versus MPA scope of practice. We are discussing that in our MPPG. Are MPAs necessary? Well, I think they're here. They've been here for a long time. We're not recognizing them for the sake of giving them an opportunity to displace medical physicists. What we want to do is describe how we can properly supervise these individuals and limit them in terms of what they can do. Implication of profession on medical physics. I mean, there's a lot of people that are pro and con against MPAs, and we just have to realize that we live in this changing world and these individuals are here. They've been here for a long time anyway. What about pay scales? What about what's happened to the medical dosimetry and how that's blossomed, and it took away from a lot of what the QMP would have done in the past? There's another medical physicist assistant responsibilities. Really some very nice discussion back and forth between the individuals that participated in these types of interactions. So, with that as background, what about the latest draft of the MPPG 7? Per is going to give you, there's going to be some overlap, but I'm mainly concentrating on the diagnostic part, diagnostic and other. This is just an example of some of the things that Lynn's list is probably about 5 times longer than this, but I just looked at some of the things that I looked on my computer and just took a snapshot of it. There's been a lot of drafts. This is only a small fraction of what I've done as well. And we've interacted actually very nicely in terms of the committee being very active in providing comments and internal discussion. And our latest draft now was just about ready to go out for public review, but we've decided to pull it back for a couple of reasons that I'll explain in just a few minutes. The first thing was we defined the MPA as an individual working in a capacity that is not fulfilled by other scope of work. For instance, the radiologic technologist, medical dosimetrist, who works under the supervision and responsibility of a QMP. So it's a fairly broad definition for MPA. The update of the supervision ratios, that thing that everybody was going nuts about because we allowed up to four individual MPAs that could be supervised by one QMP in diagnostic and nuclear. Well, here's our table, and I'm going to just concentrate on the fact that we discussed that we were going to limit. In fact, we had discussion, why don't we just make it one MPA across the board? But therapy decided not to buckle under, and they kept that 0.25, and we need to hear from Per as to the reasons why. Because I had recommended, let's just make it all 1-to-1. But we decided to reduce the FTE support in diagnostic and nuclear to 1-to-1 as the maximum, except, of course, now we have an asterisk as well. A higher ratio may be used for specific modalities provided a written justification is documented by a QMP. In no case should that ratio exceed 4 MPAs. And this would be in extenuating circumstances such as the individual that I mentioned earlier that has a lot of outpatient clinics in Never Never Land, and in that case that they're all under the same institution. That would be an acceptable component. If, in fact, individuals object to this particular asterisk, we can remove the asterisk. That's why we're having a discussion session here at this meeting. Maybe that shouldn't be there, because that's an escape clause getting back to the 4-to-1. But we put that in there just for discussion purposes. And in the therapy, I'll just leave that up for pair, but you should never have any MPA in a practice that does not have a QMP, and I think that's true in all situations. So in the conclusions, a QMP is advised to assess the use of an MPA in their medical physics practice in light of this practice guideline and implement appropriate changes. So the QMP has responsibilities. The MPA also has responsibilities. We also have responsibilities to administrators. When an organization employs an MPA, it is the responsibility of the QMP to inform the healthcare organization of the need for a supervision plan and its requirements. What this is meant to do is if you have an administrator saying, God, I can hire this MPA for a quarter of what it's costing me for even a junior medical physicist, I'm going to hire a whole bunch of them. What we need to do is make sure that the administrators know about this as well. So the QMP has the responsibility to inform the organization, the healthcare organization, for the need for the supervision plan, for the limits of the supervision plan, and this goes for those that do the hiring as well. Facility administrators are likewise advised to review the use of an MPA and address the issues described in this practice guideline. A QMP must only delegate tasks having low risk of harm to the patient, personnel, and the public. If you go back to that medical physics counterpoint, one of the things that Dr. Ezell was saying was, well, what we want to do is allow the QMP to concentrate on those things that are important for the patient and for the technical details that are minor in scope and that would otherwise take the QMP away from doing some of those higher level tasks that they're very well trained to do. That's where we want to be. We want to make sure that we don't allow scope creep of the MPA, that we allow the MPA to do those tasks that can assist the QMP in doing his or her job in a better and more meaningful way. The supervision level for the delegated task must be based on the risk level of the task and competency level of the MPA. And I know that Per is going to talk more about this as he goes through his discourse on the viewpoint from the radiation therapy physics point of view. We also have appendices, and this is where we're trying to delineate the scope of practice. And it would be impossible to delineate all the potential permutations and combinations. So we're just giving examples. The provision of the supervision plan, the QMP supervisor responsibilities are overseeing the task training, assigning the duties, assessing the performance, and evaluating the competence of these MPAs. The expectations of the MPA, and these are responsibilities that are delegated to the MPA in this MPPG, is reviewing equipment standard operating procedures, learning safety hazards, operating testing equipment, troubleshooting problems, and undergoing compliance training at the site where they are doing that particular task. So there's a lot of expectations, and this is what we're delineating in the MPPG 7 outcome. So here's an example evaluation checklist. I just extracted this from the nuclear medicine component. So it's up to the QMP to initially do training in a personal way. Then you can, based upon that training, reevaluate and determine the relative competence and do an annual evaluation. And then once you're deemed competent, you're going to check the box that says, yes, this individual has been deemed by me as the QMP to be competent in being able to do these tasks that are designated and delineated by the QMP for general supervision, not direct and not personal. And here's an example list, and this was given by one of our members who I mentioned earlier. I won't mention her name, but these are some of the things that she came up with in terms of what they allow MPAs to do. Once initial competence has been confirmed, the MPA may perform the following radiographic equipment performance tests under general supervision: half-value layer, light field, X-ray field alignment, field size indicator accuracy, positive beam limitation, blah, blah, blah. And I guarantee you that these guys that are so well trained, and that's what they do, I mean, they're zoned into those specific areas, they can do that about 10 times more efficiently than I can. I end up doing it anyway myself, but these individuals, once you've trained them, they can do a really good job. So what we want to do is not really embrace where we are. We're not trying to create a new type of what should I say, a new area of expertise in terms of the MPAs and designating that them as being a member of the physics team, but they do help us do our job. So the educational requirements is something that XCOM came knocking on my door and said, hey, we need to figure out how in this medical physics practice guideline that we don't ignore the requirements for education and training of these medical physicist assistants. So there has been a charge by Task Group 276, which is through the Education Council, not the Professional Council, to develop an AAPM statement on the educational and training requirements for medical physics assistants. And see, there's a typo. This is just extracted directly off of the web. What's wrong with that statement right there? Should say medical physicist assistant. So we just have to be careful about using that nomenclature, as been pontificated by Jerry White and others, that it's really important that it's a medical physicist assistant, an individual that assists the QMP in doing the tasks. So the bottom line was that XCOM said we need to put this in the medical physics practice guideline. We were going to export and deliver this medical physics practice guideline draft out to the public today at noontime, right, Lynn? Was that but we're going to hold back now at the bequest of XCOM. And what we're going to do, as I've indicated before, we're going to, I think there's a draft of TG 276, and I haven't talked to Stephen DeBoer, who's the chair of this yet, but what we want to do is up the ante to make sure that the minimum qualifications that are going to be required indicate the need for a Bachelor of Science in physics or a related, closely related degree that allows the ability to know that they understand some of the really important aspects of the underpinnings of medical physics. So we're going to kind of hold back, and I think we're going to try to get this out by the middle of next week, something like that. Lynn is going to be listening to what we're going to say here in our discussion. So that is where we are. The next steps are to refine the MPA scope of practice per discipline. We've done that. We're going to disseminate the MPPG 7 draft to the medical physics community for comments. We were going to do it today, but we're going to hold off for about for a week or so. And discussion of concerns, these are the next steps. So we want to discuss those concerns and then update the draft based upon the discussion. Should we get rid of that asterisk? What do we need to otherwise consider? And we want to get this out as soon as we can. The steps for review and comments, I was talking to Lynn the other day, it's about a 5-year process. So it's not something that you take lightly, and it's going to be a long-term it takes on the order of 5 years because it requires internal comments. First off, you have to develop a draft, get the internal comments, and resolve those comments. Then you send it to PC, SPG, that's the Strategic Planning Committee and the Clinical Practice Committee, and all council chairs, XCOM. They get feedback, we resolve the comments, then we send it out to the AAPM members. This is where we were right here. We were going to send it out today, but we've backed off a little bit based upon XCOM's comments back to us. And we also, after the public comment, we're also going to deliver it to various societies that have a stakeholder's interest in some of this. Yes?
Simultaneous with the public comment.
The societies are simultaneous to public. Okay, thanks, Lynn. And you can see that we have included AHRA and SROA because they're the individuals that are going to be potentially hiring these people. Then we resolve the comments. And how long does it's 30 days, right? It's 30 days of comments. Then we'll have a concurrence based upon the final outcome through these individuals. And then once that's been rubber stamped, then we go to peer review. And we'll submit it to JACMP, and hopefully by that time things will be resolved to the relatively large consensus of individual groups that have been involved in this, and we'll have a consensus document that will be published and out as a medical physics practice guideline. So we're going to hold discussion, I think. I think, Per, you should give yours, and then we can discuss some of the issues that both of us have given.